My name is Dr. Katz. I'm a non-invasive cardiologist with a special interest in preventative cardiology. And in today's video, I'm going to be talking about high cholesterol. The first thing that I want every person to know about high cholesterol is that the higher your cholesterol over a longer period of time, the higher your future atherosclerotic cardiovascular disease risk, or the higher your risk of having a heart attack, stroke, death. Now, just because you have high cholesterol doesn't mean that you are going to have a heart attack or a stroke. It just means that you're going to have a higher lifetime risk. This is a fact that 99.99999% of cardiologists agree on, and the other 0.001% of them are probably quacks. How doctors communicate and treat cholesterol is imperfect. The dietary restrictions or recommendations that we provide are not perfect. I'm not perfect in following my own recommendations day to day, but I try my best to live my life in a similar enough fashion to the advice that I give my patients. So again, high cholesterol leads to a higher risk of future heart attack, stroke, death. Cholesterol deposits in the artery walls in the process of atherosclerosis. Over time, that causes narrowing of the arteries, causes soft plaque to build up, and can be vulnerable to rupture. If that happens in the brain, it's a stroke. If it happens in the heart, we call it a heart attack. Now, just because you have high cholesterol doesn't mean you're going to have those things. And just because I give you medicine or you change your diet and lifestyle and lower your cholesterol doesn't mean that you're not gonna, but it does mean you're gonna have a lower risk. I have 40-year-old patients who run marathons, eat right, don't smoke, and have a heart attack. And an 85-year-old who smokes, drinks, labs are through the roof, and is relatively healthy. The point I'm trying to make is that a lot of health is the cards you're dealt and how you play them. Your genetic predisposition or your family history is something that you can't change. It's cards you're dealt. And the choices we make in our lives, the lifestyle we lead, how active you are, food you eat, whether you smoke or not, all those little things can improve or worsen your risk of future heart attack or stroke. Now, before we get into diet and lifestyle things that cardiologists will agree on that can improve your cholesterol, let's understand what those cholesterol particles are and which ones are more or less important. To me as a cardiologist, the most important one is LDL cholesterol, the bad cholesterol. The reason it's considered the bad cholesterol is that it's atherogenic. It causes deposition of cholesterol fat plaque in the artery walls. It's an imperfect biomarker, I admit. I have patients who have had normal cholesterol levels, still have a heart attack. People who have really high cholesterols and haven't had one. And maybe they never will. Again, life is not a zero risk game. All I'm trying to do as a cardiologist is reduce that risk. So the LDL is the bad cholesterol for primary prevention. For people who have never had a heart attack or stroke, we want that about less than 100. One of the things that frustrate me a little bit about medicine is how we communicate changes in guidelines. I know that previously we wanted it less than 130, and now we're a little bit more stringent. We want it less than 100 for primary prevention. And part of that is just that the science evolves, and we find that a lower value is a little more beneficial. There are risk calculators, and they're imperfect. They don't include a whole lot of data and a whole lot of cardiovascular risk factors, but they're one of the tools that we can use to try to better risk stratify people. Now, the LDL goal for people who have already had a heart attack or stroke, or people who have peripheral vascular disease or narrowing of the arteries of the legs, where we have evidence of it, where you already have that disease, we want to drive your LDL less than 55. We know that the lower the cholesterol, the better. And for reference, I get concerned for a familial hyperlipidemia or an inherited disorder of lipid metabolism when your LDL is greater than 190. Often those people, regardless of what you're doing, should be on medication to lower it. Because people who have a familial inherited lipid disorder are known to have a much higher risk compared to the general population, regardless of what your LDL level is. Inherited familial hyperlipidemia or high cholesterol from a true inherited genetic mutation is a little bit outside the scope of this video. Those people generally are young, otherwise healthy. Sometimes they're older when we discover it and have LDLs greater than 190. So LDL's the bad cholesterol, HDL's commonly known as the good cholesterol. Not that I don't care about it, but the reason I don't care about it that much is that there's no medication that we found that reduces your mortality. We used to treat it with niacin to raise your HDL, but we found that we weren't keeping people alive longer by raising your HDL artificially with medications. So generally the way I look at HDL is that if it's high, it's normally a good marker. If it's low, it's normally a more worrisome marker. But that in and of itself, I'm not going to target or try to change. Triglycerides are another portion of your lipid panel. And generally, we don't want it really high. When it's In the thousands, it can cause acute pancreatitis and can be a very serious issue. Generally, for most patients, we don't want it too high because high triglycerides have also been associated with worse outcomes. And generally, I try to target a triglyceride level less than 175 or so. Most of the guidelines support using medications to lower the triglyceride levels to less than 175 if you're already maxed out on other cholesterol-lowering medications and you're still at a high risk of future heart attack or stroke, specifically in people who have already had one. I'll get into what medications we use for that a little bit later in the video. The two other particles I want to mention are lipoprotein A and apolipoprotein B, or LPA and ApoB. These are two smaller particles that travel with LDL and are also atherogenic. They're bad cholesterol because they can increase the deposition of cholesterol, fat, and plaque within the artery walls, increasing your risk of future heart attack. Now, we don't really have any specific medications to target these two particles. ApoB is mostly found in LDL, so inadvertently, any medication that we use to lower LDL kind of also lowers ApoB. And LPA, we don't have any medicines to use that can treat that yet. There are ongoing trials, so I'm sure in 10 years, this video is going to be out of date. But what we do know is that people who have elevated LPA markers have a future higher risk. To me, it's another biomarker that I use to say, all right, what is your LDL level? What's your LPA? To help me see, is that a slightly better LDL where maybe we can forego the medication? Or is that LPA really high and maybe we should try to treat it to get that LDL a little bit lower? So overall, LDL is a bad cholesterol. ApoB and lipoprotein A are two small particles that are bad because they are atherogenic and travel with the LDL or bad cholesterol. We can kind of use them sometimes as markers of, are they a better or worse LDL, kind of increase or decrease the risk that that intrinsic LDL has. At least that's how I kind of use it. And we don't have any medicines that lower lipoprotein A or LPA right now, but there are ongoing trials to see, can we lower it? So why do doctors talk about diet and lifestyle so much when we're talking about cholesterol? To me, it is because we can't change our genetics or our family history, but we can adjust the things that are in our control. Do you smoke? Do you exercise or stay active regularly? And what is your diet composed of? Now, I'm the first one to admit doctors don't know everything about nutrition. Nutrition is an intrinsically hard thing to study. In my opinion, if someone is ever telling you that if you eat only this thing for the rest of your life, you're going to cure all your ailments, they're trying to sell you something and they're full of it. My general recommendations for a heart-healthy diet, and by my recommendations, I mean most cardiovascular disease society guidelines, are going to be low saturated fat diets. That doesn't mean no saturated fat, but you don't want to have an excessive amount of it because saturated fat can increase that atherosclerotic burden. You want to eat healthier fats, like poly and mono unsaturated fat, things like omega-3 and omega-6 fatty acids, often found in fish, healthy oils like canola and olive oil, avocados, healthy fat. Other foods include a lot of nuts or tree nuts. It's the same thing like looking at an apple and candy. They're both carbohydrates, but an apple is certainly a healthier option to get sugar in your diet. Same thing with fat. I choose personally and recommend a low amount of saturated fat. Things that are solid at room temperature. Butter, steak with marbled fat within it. I do not eat coconut oil. Might be good for the hair, but I would not eat it. I mean, if you're baking and you use a little bit, it's not the end of the world, but like I'm not cooking with it routinely. Low saturated fat is what we find works best, and not eating an excessive amount of dairy. I don't follow that recommendation that much. I really do love cheese, quesadillas, milk, but I try to limit the other areas of eating excessive saturated fat. For instance, if you eat 3 eggs with the yolks in them, that's about 14 grams of saturated fat. That means you've got no extra room for any other cheese, dairy, meat in your diet that day, if you're following a strict low saturated fat diet. So for breakfast, I'll have a boring, healthy oatmeal. Again, I'm willingly acknowledging that we don't know everything about nutrition. For some reason, people think that keto diets are the answer. And certainly I think if you're on a keto diet and somehow you're able to get all of your protein from not always animal sources, that it's probably not the worst thing in the world, but a purely keto diet from animal-based products is not something I'd recommend. Again, if that's what you choose to do, that's fine. I'm not going to argue with you over the internet that eating an excessive amount of steak and red meat is bad for you. That's just what I believe and what all of the guidelines indicate. Maybe we'll find out we're wrong, but it's not something I recommend. Additionally, there's a large group on the internet who think that canola oil and olive oil are really evil and terrible for you. I don't understand where their fervor and confidence comes from. It's not like I use that type of oil excessively, but that is part of the Mediterranean diet, which is fish, healthier mono and poly unsaturated fats, also found in olive oil. So if I'm cooking something, I'll use olive oil. I am not a proponent of weirdos on the internet taking shots of olive oil every day. I think you should just use it if you're cooking. But if you're one of those people that want to take a shot of olive oil every day, I guess I'm not going to stop you. And I certainly empathize with patients, because sometimes you'll go to one doctor and they say you need to have this type of diet to prevent your diabetes. And then you go to another doctor and they say you need to have this type of diet to prevent heart disease. And another doctor says avoid these foods to prevent kidney damage. And you're left being like, what am I supposed to eat? But overall, I think that diets that are going to help prevent you from becoming diabetic, prevent you from having high blood pressure, and prevent cardiovascular disease, like a Mediterranean style diet, a vegan diet, are certainly healthy options. Technically, a vegan diet is probably the healthiest option for your heart, but I ain't gonna do that. But I certainly try not to eat red meat every single night. I try not to eat an excessive amount of cheese every single night, although I probably have too much. So one of those other recommendations that I normally give is not having an excessive amount of sugar. You know, yogurt, for instance, is a healthy food option, but the ones that I like that taste good, I use as a dessert, because some of them have like 17 grams of added sugar, and some of the really healthy ones taste really healthy. So I personally eat yogurt that has a high protein content and not a lot of added sugar. And that's what I look for in most products. Low added sugar amount, not a lot of high fructose corn syrup, and trying to avoid pro-inflammatory foods. And I don't think I'm being unreasonable where I just say everything in moderation. I'm not saying you can't eat steak. My best friend has high cholesterol, and we were talking about high cholesterol food over lamb chops. I mean, he looked at me like we were crazy. He was like, shouldn't we not be eating this? And I was like, whoa. You have high cholesterol, I don't. But also, you can have red meat every once in a while. There's a big difference between patients who tell me they eat red meat once in a while, which is once a month, and my other patient who said, yeah, I eat it once in a while. And I said, how often is that? And they're like, for dinner. I was like, well, how often for dinner? And they're like, no, every night for dinner. To me, that's too much. So as a cardiologist, that's what I recommend based on every cardiovascular disease society guideline in the world. You can choose to disagree, and that's okay. If you want to share some guidelines or research, I'd be happy to review it. I'm willing to see if there's a different perspective. I'm just letting you know now that as I've had this happen in the past, if you engage in this video in a disrespectful way, I'm just going to delete your comment and block you. I don't have time in the day for that. I actually have a day job. So overall, high cholesterol increases your future risk of heart attack, stroke, death. Doesn't mean you're gonna have it, just means you're gonna have a higher risk. All I'm trying to do is lower that risk. It's like trying to refinance your mortgage on a home. If I could lower my imaginary mortgage from 7% to 6%, you know I'd do it. And same thing, if I could lower your risk of a heart attack in your lifetime from 4% to 3%, I'd take that. And I apologize on behalf of doctors, because I think we go a little overboard on slamming home diet, diet, diet. Because I tell a lot of my patients who are doing everything they can to lower their cholesterol that sometimes you can do everything right and still just have high cholesterol. On top of that, just because we use medications to lower it doesn't mean you can't have a heart attack. Just because we don't get your cholesterol to where we want it to be with or without medications doesn't mean you will. I'm just trying to lower your risk. That's my goal. Now, there are some other causes of high cholesterol. And when I see someone with high cholesterol, we want to look and see, do you have new onset diabetes? Sometimes controlling your diabetes brings your cholesterol down too. Some people with hyper or hypothyroidism can cause cholesterol metabolism to be a little wacky. And it's a simple blood test to rule in or rule out. And if treated appropriately, sometimes that cholesterol can go away. Sometimes excessive alcohol intake can increase your triglycerides specifically a whole lot. There are some medications, specifically antipsychotics like olanzapine, that can mess with your cholesterol and make your triglycerides and sometimes your LDL really high. And sometimes we just have to work with your psychiatrist in order to figure out what the right regimen is, or if we just have to keep you on that medication and try and treat your cholesterol. So how do we actually treat high cholesterol? The first line therapy are statin class medications. They end in statin, atorvastatin, rosuvastatin, pitivastatin. You get the drift. There's a lot of misinformation online, and I want to share at least what I tell my patients when I'm starting them on a cholesterol lowering medication in the statin class. Typically, I like to use atorvastatin and rosuvastatin. I see a lot of patients as a cardiologist who have already had heart attacks, strokes, bypass, peripheral vascular disease, where we already have evidence that you have narrowing of the arteries, and we want to prevent that from getting worse. Statins can lower your cholesterol depending on the dose, depending on how you respond to it, anywhere from 30 to 50 or 60% sometimes. And again, I'm looking at your LDL. I want that lower. Typically, we start you on one dose, we wait 3 months and recheck the cholesterol. That should be enough time to see that cholesterol come down. I don't want to check it too early and inaccurately say that you didn't respond enough to it. And I don't want to wait too long, because if you're not responding, sometimes we'll switch from atorva to rosuvastatin, from Coke to Pepsi. Or sometimes it comes down, but just not enough, and you need a second medication. Sometimes you don't respond at all, and you need an alternative medication. Statins, contrary to common myth, are relatively safe medications. They've been well studied, and the most important aspect that your doctor should be looking at is weighing the benefit with the risk. Take, for example, aspirin. Recently, there are many studies that showed we shouldn't be prescribing it to everyone for primary prevention, for people who've never had a heart attack or stroke. It used to be the only drug that we had, so we were like, wow, this is preventing heart attacks, give it to everyone. But eventually we found when you give aspirin to a low-risk individual, the very small but real risk of GI issues or GI bleeding, sometimes kidney issues, outweigh the benefit of reducing your risk of stroke or heart attack. So I don't recommend we use aspirin for every patient of mine. And same thing, we should be making sure that using a cholesterol lowering medication has a greater benefit than risk. There are some older statins that were taken off the market because they had bad side effects, worse than what we have today. And there's a history of bad medications that doctors use. And I truly understand and empathize with the general public about the distrust of big pharma. You don't have to look too far back in our history to see, for instance, big pharma lying to doctors and saying opioids, for example, are non-addictive when clearly they are, and doctors giving them out like candy, and it caused a lot of harm, and we're dealing with the repercussions of that. So I truly understand people's distrust of big pharma. Now, I don't like big pharma, but at least when I prescribe a medication based on FDA guidelines, the pharmaceutical company has to prove that what I say is going to be in the prescription actually is what's in the bottle. But as much as I dislike big pharma, I really hate big supplement, because they don't have to prove what's in the bottle is actually what they say is in the bottle. And if anything, they're out to get your money just as much, if not more, than big pharma is. And I don't want to get too sidetracked, but if there's someone on social media, on the internet, saying that doctors are idiots, they don't know anything, use my supplement and you'll be cured of all your disease, they're probably just out there to take your money. I know that doctors also have a financial benefit to treat patients, but I truly just want my patients not to have heart attacks. That's why I don't sell supplements. That's why I don't promote them. That's why I turn down routinely supplement companies who want me to sell their supplement versus other people online who are practicing way outside the scope of their practice who sell their own supplements online. Off my pedestal, back to what we were talking about. What were we talking about? Statins. Now, that being said, there are some real side effects that statins can have. But for the most part, when I'm treating my patient with cholesterol lowering medication, I want the benefit to outweigh the risk. So overall, the benefit of cholesterol lowering therapy to lower your cholesterol, to lower your risk of heart attack or having another one, far outweighs these risks. Every patient's different. You should talk to your doctor if you're concerned about cholesterol lowering medications. The most common symptom that people can have are statin associated muscle symptoms. I've had patients whose knee hurts, their thigh hurts. Often it can happen in big muscle girdles like your hips or your shoulders or your back. Sometimes if you work out, your muscles might be more sore than they normally are. Sometimes people can have headaches, muscle aches, cramps, any number of symptoms. What I typically have my patients do, if it's something that's not too intolerable, is stop your medication for a day or two. Wait for that symptom to go away, and then re-challenge yourself to see, does that symptom come right back? Because sometimes you can have a temporally related phenomenon or something that happens that's unrelated to your statin or your lipid lowering therapy, the medication, and it just happened to happen the same time as when you took your cholesterol med. I'm not joking when I say I had a patient who stubbed their toe on their bed frame, came in and said, your medicine made my toe hurt. And after we talked about it, I elucidated that they were a little bit concerned maybe their toe hurt more than it should. So we had him stop the cholesterol medicine for a week, and then he restarted it, and he didn't notice any more toe pain, and it hadn't come back. So similarly, in a more serious note, if you have muscle symptoms, I hope your doctor listens to you. I feel bad that sometimes patients come in and they're like, well, no, the doctor didn't listen. He or she just said, take the medicine, it's in your head. There are some, I know medicine better than you, but you know your body better than I ever will. So I just hope that you have a doctor that listens to you and tries to work with you and either try a different medication, try a lower dose, or if you have to, stop the medication. And the reason there are other medications that exist on the market today is because people do have symptoms that can be real enough that they can't tolerate. And that's also why I don't typically prescribe the max dose of these meds. Sometimes we have to. Annoyingly, for us to get approved sometimes by insurance companies for the second or third line medication, we have to prove that you failed the highest dose. It's ridiculous that if you can't tolerate the medium dose, why would you be able to tolerate the high dose? But literally sometimes big pharma or big insurance makes us prove that, like, yeah, your cholesterol didn't come down enough on the highest dose, which you couldn't tolerate because we couldn't even get you on the medium dose. But that's the game we have to play with insurance companies sometimes. I think I hate big insurance more than I hate big pharma and big supplement, but that's the reality of the world we live in, at least in America. The other thing about cholesterol medications, specifically statins, is you get a little bit of a diminishing rate of return as you go up on the dose. So normally every time you double the dose, if you go from 10 milligrams to 20 milligrams of atorvastatin, which is Lipitor, you might get another 7% incremental reduction in your cholesterol lowering ability, which is good. But to me, that's not a good enough rate of return to go from 40 to 80 because I don't have exact science to prove. I'm sure a cardiologist smarter than me or someone can find a study that proves this. But I find that the higher the dose, you don't always get much more cholesterol lowering with it, but you do get a slightly higher risk of side effects. Now, super rarely, and I mean exceedingly rarely, you can have statin-associated myositis. This is where you have actual breakdown of muscle, where if you check a blood test, you can see creatinine kinase, or CK, which is a marker of breakdown of muscle tissue, can be positive. That can be life-threatening. It can cause kidney damage if the enzyme levels are too high, and is very serious. So generally, if my patients are having minor aches and they're like, I can't tell if it's the statin, tell them to stop it for a day, see if the symptoms go away, try it again and see if it gets better. Versus if they're having trouble like lifting their arm, or they're in severe pain, which is abnormal for them, not only will I tell them to stop the medicine, but also check a blood test like a CK in order to make sure they're not having rhabdo or breakdown of muscle tissue. Again, it's a rare side effect. It can happen. And generally, the benefits of the medicine outweigh that very small risk. Other side effects of statin medications is that can raise your hemoglobin A1C. Hemoglobin A1C is a marker of diabetes. We use it to measure how much sugar has been in your bloodstream over the last 60 days. Your red blood cells last in your body for about 60 days. Your spleen recycles. In that time period, there's sugar in your bloodstream. It naturally attaches to your red blood cells. So it's a good marker to see what's your average blood glucose level been over the last 60 days. We use it to measure, are you diabetic, pre-diabetic, or not? And sometimes it can cause a relatively negligible 0.1-ish increase in your hemoglobin A1C. But again, generally in the right patient, the benefits outweigh the risks. The other caveat that I have, and a reason that people don't like big pharma, don't like cholesterol meds, is that based on current guidelines, everyone who's a diabetic should be on cholesterol-lowering medicine. And that's because diabetes increases your risk of heart attack a whole lot. Now, I understand people's trepidation with cholesterol meds, with doctors pushing them, because if every diabetic has to be on a cholesterol med, that's a huge market. We're just medicating everyone. I agree. If we can control your diabetes, reverse it, that'd be ideal. But diabetes increases your risk of cardiovascular disease a lot. And if it's not well controlled, putting you on a cholesterol-lowering medicine to get that LDL lower is what we sometimes do. Medicine isn't perfect. I'm just trying to reduce your risk of heart attack or stroke. I'm trying to refinance that home mortgage. The other thing that statins are associated with is lowering your coenzyme Q10 level. This is some random enzyme in your mitochondria that was studied. The long and skinny of it that I take from these studies is that having a lower coenzyme Q10 level didn't really have any negative side effects or outcomes, and that supplementing people with coenzyme Q10 didn't reduce their risk of symptoms. Now, that being said, I have plenty of patients who tell me they take coenzyme Q10 and it makes them feel so much better, so much energy. They don't have any symptoms from their statins. Hey, I'm happy. I'll take that. I'm not pompous enough to say, hey, you think that this thing's helping you or it is helping you? Stop it. Maybe there are certain patient populations who do benefit from it. I don't know. Again, I don't promote it. If my patient wants to take it, I'm not going to stop them. But again, it's another thing that if I see someone selling it online, telling you that cholesterol's not the enemy, you have to take these supplements and it'll prevent everything, doctors are the idiots, I become a little wary that what they're really trying to do is sell their own supplement and make some money. So just beware of people selling misinformation online with regards to cholesterol and coenzyme Q10. Generally, we haven't found in studies that supplementing it really prevents much or reduces symptoms associated with side effects of statins. Another side effect of statins sometimes is a mild increase in your LFTs, or your liver function tests. On your blood work, this might be your ALT, AST, and ALP. Generally, the elevations in your liver enzymes are not significant and don't have any negative outcomes, and generally you can continue the cholesterol med if your liver enzyme elevations aren't significant. Different guidelines have different recommendations. Generally, if you want to check it, you can at baseline and at 12 weeks or 3 months when you recheck the cholesterol to make sure that it's still normal, and if you want every year, but that's a conversation you should have with your cardiologist. For the most part, in large Cochrane reviews, they found that statins didn't have that much of a high risk of causing liver function test abnormalities, and often there was something else going on beneath the surface that could have been contributing to it or causing it. But it's something to be aware of. So again, overall, the elevation in the liver function tests, I'm not too worried about as long as those liver numbers don't go too high. And I don't often routinely will retest them, but if someone has some underlying liver disease, I might. Again, overall, for most patients who I'm prescribing cholesterol lowering medication for, the benefits often outweigh the risks. Another thing that a lot of proponents against statins will tell you is fatty liver. Now, if you are diabetic, if you have high cholesterol, if you're overweight, fat, cholesterol, plaque goes to your arteries. It also can go to your liver. So often we'll find that people can have a fatty liver around the same time that we discovered that they have high cholesterol or that they have diabetes. There are a lot of causes of fatty liver. Generally, lowering your cholesterol is associated with an improvement in fatty liver outcomes, and it helps your fatty liver. So in general, statins don't cause a fatty liver. One other piece of misinformation that I wanted to talk about was the supposed risk of Alzheimer's disease with taking statin therapy. Now, some studies looked at older individuals who may have developed dementia and what meds they were on. This was correlation and not causation. They didn't prove that the medications cause dementia. And in fact, when we did some follow-up observational studies, we could not find that link. In fact, when I talked to my neurology colleagues about what causes dementia, first off, there are many different types of dementia. One of them is vascular dementia. And when we look at that, things that cause atherosclerotic cardiovascular disease also can lead to dementia. Things that limit blood flow to the heart are going to limit blood flow to the brain. So things like good exercise, low cholesterol, not smoking, controlling your blood pressure, good genetics are all things that are going to decrease your risk of heart attack, as well as potentially developing certain types of dementia. So if you have really high cholesterol, I view taking cholesterol medications, if anything, as potentially being a little bit protective. Certainly proponents will say also that we need cholesterol. Your brain's made of cholesterol. And while I agree your body does need a little bit of cholesterol to function, and we don't know what the lower limit of acceptability is for lowering your LDL, I've had maybe 1 or 2 patients in my career so far where it gets so low, I'm talking the LDL in the single digits, that we needed to change her medical therapy. And in that instance, when her LDL was in the single digits, we backed off. But overall, I certainly agree. I don't want to develop dementia. There simply isn't a strong connection between dementia and statin therapy. And if you're concerned that it's statins causing you to have low cholesterol, we have other medications that we can use to lower your cholesterol too. I have patients who refuse to take statins, but I'm willing to work with them to lower their cholesterol to a safer level. So now how else do we manage cholesterol? Let's say we max you out on a medication that you can tolerate up to a certain dose, and your cholesterol is still not at goal. The most common second drug that can work together with statins is Zetia or ezetimibe. It works a little bit in a different mechanism. It can help work symbiotically with the statin to lower your cholesterol even further. So if we get your LDL, start you on a statin, check it in 3 months, and it's not quite where we want it to be, we'll add on a Zetia and recheck it in 3 months. Again, depending on the scenario, I'm perfectly happy to wait to see if a patient, isn't eating right, wants to lose weight, wants to treat the underlying root cause of everything that's going on. We have time, especially in primary prevention for people who haven't had these large cardiovascular events. But sometimes, despite eating right, controlling stress, anxiety, cutting out excessive alcohol, eating right, and doing everything good, your cholesterol can still be high. And in those cases, we have to have a conversation about what's the benefit for this versus the risk. The unfortunate reality with cholesterol lowering medication is that you do have to be on it for a long period of time. The number needed to treat, meaning the number of patients I have to give this medication to prevent one major adverse cardiovascular event, one heart attack or stroke. You have to treat, depending on the medication in the study you look at, about 75 patients for 2 years to prevent one event. That's a very high number needed to treat. And if you look at the data and the pathophysiology of atherosclerosis, of how cholesterol deposits in your artery walls and causes these issues, it kind of makes sense. If you have high cholesterol, it takes decades for that cholesterol to deposit in the artery wall and reach a breaking point that eventually causes that heart attack. So if we start a cholesterol lowering medication today, it's going to take years to see that over time, it slowed down that progression of that disease. So there's a long lag time between when we start something to lower cholesterol and the clinical benefit. So I certainly empathize with people where it's like, oh, I got to take this medication for the rest of my life. And for people who have already had a heart attack or stroke or something like that, yeah. I mean, again, I'm your cardiologist. You can choose to take my recommendation and throw it out the window if you want. All I can do is say that these medications and lowering your cholesterol will hopefully help prevent another event, or at least reduce that risk, trying to refinance that debt. Now, to me, the other interesting thing about how we manage cholesterol that I think is going to change over the next couple of years or decade is that if you look at a 30-year-old who overall has a low risk of heart attack or stroke because of their age, and they have an LDL, let's make it up, of 150. Let's say they fix their diet, they exercise, do everything right, still 150, doesn't change. Probably have some genetic component. Now, most people would say, you're pretty young, I don't think we need to get you on a cholesterol-lowering medication. Let's advance 20 years. And their LDL has been 150 that entire time. Now they're 50 years old and they're higher risk simply because of their age. A lot of doctors appropriately are going to say, you're a high risk, we should lower that cholesterol. And if they wait those 20 years to start a cholesterol lowering medication, the only thing that's changed is that we haven't refinanced that loan. Their debt of atherosclerosis is compounding in time. It's getting worse over that 20 years. So I don't love using cholesterol lowering medication in young patients for years, but sometimes you have to, especially in people with familial hypercholesterolemia, where you have a young individual whose cholesterol is through the roof. We know that those people are gonna have a higher risk of future events, and I wanna get it lower immediately. To me, cholesterol is compounding interest with either a good investment or really bad debt, depending on if you control it or not. Another question a lot of people say for primary prevention is, do I have to be on this for forever? And the honest conversation I have with people is that it's not unreasonable that they don't want to be on a medication for forever. So sometimes what I'll do with them is acknowledge that a little bit of statin does go a long way. There is some research to show that if you're on it for a little bit of time, we get your cholesterol down. The way that I look at it is you got debt, it's still compounding in interest, but we're gonna pay off a big chunk of it. So it's still compounding interest, you're still human, you're still gonna develop atherosclerosis. But if we get you on a cholesterol lowering medication, lower it for a little bit of time, what I typically will do for patients who want to come off of it, and I hope that they can trust me enough to say, hey doc, I want to stop this med and I'm going to, instead of falling off, not following up with me for years and saying, oh yeah, I stopped that medicine. I'd prefer people just tell me, I really want to stop the medicine, can we? And having that conversation. So what I'll do for those patients is I'll say, just like when we started it, we check in 3 months, all I want to do is if you stop it, let's at least do an experiment and see, does your cholesterol slowly creep up over time? Which sometimes it does, but other times it will, instead of creeping up, it'll go way right back up. And in those patients, it makes me think that they probably have a higher intrinsic risk of having longer term risk. And maybe we can lower the dose. Maybe we can work with you and do something else. But the unfortunate reality is, if my cholesterol was that high and I came off of it and it rebounded like that, I would want to be on a cholesterol lowering medication. So statins are still first line therapy. They're relatively safe, and the benefits certainly often and should outweigh the risks. Second drug to lower cholesterol often is Zetia, and you use it in combination with cholesterol lowering medication of statins. You can get away with using Zetia alone, and it does work, but statins, again, are first line therapy. If I get someone on atorvastatin or a statin and Zetia and their LDL is still not at goal, the next step is often a third line medication. That can include bempedoic acid. So you're taking 3 medications now, although they do sell a combination where you could do Zetia and bempedoic acid together, so it's 2 pills but 3 meds. Sometimes it's fighting with insurance companies, it's an oral pill, and that can bring it down a little bit more. And if that brings you down to your goal, fantastic. And whether your insurance company approves it or not, or if you just prefer to use this, we will use Repatha. That's a PCSK9 inhibitor. It's an injection every 2 weeks, and it helps reduce your cholesterol even lower. Often I'll use it with atorvastatin and Zetia, but if a patient is using these medications, Zetia, Repatha, bempedoic acid, because the statins were causing symptoms, you can use it without the atorvastatin. That individual management is going to be up to you and your cardiologist. There's a new medication called inclisiran, which is actually once every 6 months, and it's another option that we have. Another medication we use to lower triglycerides specifically is icosapent ethyl. One of the brand names is Vascepa or Lavazza. These are prescription omega-3 fatty acids and have been shown to lower your triglyceride levels, specifically in patients whose triglyceride levels are through the roof, or in patients with known coronary artery disease who have had a heart heart attack or stroke and their triglyceride levels are not below 175, there has been shown to be a little bit of a mortality benefit in lowering their triglycerides more. That's when I'll reach for those drugs, when the triglycerides aren't low enough, because statins do lower your triglycerides a little bit too. Sometimes insurance won't cover it, and we'll use fenofibrate, which is a different medication that lowers triglycerides by decreasing intestinal absorption of it. So all this to say, we have a lot of tools in our armamentarium to lower cholesterol, and some of them do have risk, but I'm hoping that your doctor will use them appropriately where the benefit outweighs that risk. Now, since I was just talking about omega-3 fatty acids, but a prescription strength, what's the difference between the prescription and over-the-counter omega-3 fatty acids? The main difference is that we can prove that it has the right proportions of the omega-3 fatty acids in them. Again, omega-3 fatty acids are poly and monounsaturated fat, the good fat, and it helps lower triglyceride levels. I think doctors kind of did this to ourselves, where we studied Inuits in Alaska and we found they eat a lot of fish, they have a high omega-3 fatty acid intake, they have a lower risk of heart disease. But I think we've kind of missed the forest for the trees on this, where we found, just like with the Mediterranean diet, people who eat a healthy diet have a lower risk of heart disease. But we pushed omega-3 fatty acids, and we finally actually found over years of research that not all omega-3 fatty acids are created equally. There's a correct proportion of EPA and DHA, which are two omega-3 fatty acids with a really long name, and they have the right proportion within that pill. So again, I don't like big pharma, but at least when I prescribe it, I know that it has the appropriate proportions that I want my patient to be on. Versus the over-the-counter omega-3 fatty acids, they don't have to prove what's in them is what they say it is. You know, for instance, I love Costco. I like truly love Costco. And I hope that what they say is in their pills is actually in their pills. But I have no way to prove that they're right. And because they're not FDA regulated, because they're a supplement, they don't have to prove it. And if you're taking the wrong type of omega-3 fatty acid, it can worsen your cholesterol. So I do not typically advise people to take over-the-counter omega-3 fatty acids. In fact, that's one of the few medicines I normally tell people, if we're managing your cholesterol actively, stop the over-the-counter one. But again, that's a conversation you have to have with your cardiologist. Not to mention the prescription ones often have less of a bad fishy taste in your mouth. Now, speaking about supplements, one that I actively tell patients and advise them not to take is red rice yeast. Red rice yeast does have an active ingredient in it that lowers your cholesterol. It does work. The reason I don't like it is that the active chemical ingredient is the same ingredient that flovastatin is derived from, another statin drug. So when you're taking this supplement, you're actually just taking a cholesterol-lowering statin. The difference between flovastatin and red rice yeast is that when you take red rice yeast, you don't know what dose you're taking. It's not FDA regulated, and the company doesn't have to prove that what they say is in them is what's in them. In fact, in a 2017 review of over-the-counter supplements of red rice yeast, they found that there's a 60-fold difference in the amount of the active ingredient in the pills. Meaning, I could be giving you a 1 milligram pill, or it could be 60 milligrams. And the funny thing is, in 2 of those pills, there was 0 of the chemical compound in it. So they were just literally taking your money and not doing you any good. And again, the reason that I prefer an actual medication to supplements is that we know the dose you're taking is the dose that I prescribe, versus supplements that don't have to prove what's in them is actually what they say is in them. And if you're worried about statin side effects, imagine taking a pill that might have the dose that you think it is, or it might be 60 times more than that, or 60 times less than that. Big pharma certainly wants your money, but big supplement is not your friend either. Other supplements that people seem to harp on is K2. I looked at the available research from the American College of Cardiology, who did a great research article review on it, and they found that right now there is 0 evidence to prove that it works. They think that it might help decrease calcification of the arteries or valve, and they literally said in that review that we need more study on that. So maybe in the future we'll find something that is useful for that. And again, if a patient of mine truly thinks that this is helping, I want to at least help prove them right or wrong by checking what is your cholesterol when you're taking this supplement. What I care about is making sure that my patients are safe and reducing their risk of future heart attack or stroke, keeping them out of the hands of my interventional colleagues. So the first thing, if you're taking a supplement, just tell your doctor. I just want to know that what I'm giving you isn't going to interact with what you're taking, but I do not advise people to take this supplement. It isn't proven, and to me, it's a waste of money. Again, I've said this multiple times in the video, I'm willing to listen and hear other people's ideas, but also if it actually had a benefit, don't you think Big Pharma would have bottled it up and sold it to you for like $1,000? I'm skeptical about that supplement and don't believe in it and don't advise it to my patients. There's no evidence to prove that K2 does anything. Now, as for other supplements like garlic or onion or turmeric, there's some studies that showed that turmeric can help reduce inflammation. And again, I do prefer medications than supplements. But overall, if you're taking a garlic or onion or some type of supplement like that, I don't always have that big of an issue with it. I just encourage you to talk to your cardiologist about it and tell them what you're taking. The last thing I'm going to talk about in this video is people online who are not doctors or doctors well outside their scope of practice advocating for certain types of diets or supplements. I, as a cardiologist, would never dream of giving advice about OB-GYN or obstetrics or orthopedics, because that's just outside the scope of my knowledge. I might be able to see a broken femur if it's on an x-ray or sticking out of your leg, but I would not take you to surgery thinking that I know what I'm doing. And likewise, as a cardiologist, I treat a lot of patients who have had heart attacks, strokes, debilitating disease, and I'm trying to prevent them from having another. I'm trying to weigh what's the risks associated with this medication, and hopefully the benefits far outweigh them. I would just be very cautious listening to someone who's talking outside of their scope of practice. I'm not trying to talk down on chiropractors, but unfortunately online I see a lot of them talking about cholesterol. It dumbfounds me why they think that they're qualified to be doing that, and the advice that they give often directly contradicts every piece of evidence that the field of cardiology has to offer. Certainly, I think doctors and cardiologists can do better at communicating what we do and why we do it. But overall, I hope that patients can understand that we're trying to make sure that the benefits outweigh the risks associated with high cholesterol. That was a lot, and I probably missed something important. What I'm hoping is that this can at least extend the time that I share with my patients in the clinic. And if you're one of my patients and watching this video, hopefully I covered a lot of this in the clinic already with you. And I hope that if you're a patient who I don't see, that you feel comfortable enough addressing your concerns with your doctor. A lot of times people comment on my videos asking questions about their care or what they're doing. And what I really want them to do is talk to their doctor about it. I know that we don't have all the time in the world, but I hope that maybe you can make an appointment with them and have them actually address your concerns. Overall, there's a lot of misinformation online, and generally, the lower the cholesterol, the better. My main goal is to lower my patient's risk of having a heart attack or stroke or some debilitating illness. And sometimes medications have to be used. Cholesterol is one of those things that you might be able to blame your parents on. Cholesterol is strongly genetic, and doctors unfortunately harp on nutrition because it's the one thing in our control. You can't outrun a bad diet or bad genes, meaning you can't out-exercise a strong family history or bad genetics, meaning there's no extra amount of exercise that you can do if you have a strong family history or some genetic mutation that causes you to have really high cholesterol. You can stay active, which helps. You can eat right, which helps. And there's a lot of misinformation online about what the right diet is. I'm at least humble enough to say that doctors don't know everything, but my general rule of thumb is everything in moderation. If someone's telling you that you should only eat meat, I would at least question what their motivation is. If you have any specific comments or questions, I'm happy to answer them. I can't answer questions specific to your medical treatment, but I can answer general medical questions. And lastly, if you made it this far in the video, if you harass me or bully me or call me bought by Big Pharma, I'm just gonna block you and move on with my life because I don't have time for that. I hope this video helped. Let me know what I should cover next.